There we go. Now let me get back to my script here. Sorry. I will start again. Hello, I'm Allen Henderson, the Executive Director of NATS, and I want to welcome you to our discussion today, Teaching COVID-Impacted Singers. The significance of this week in the lives of the performing arts and in the voice teaching communities is not lost on us, as few of us would have thought that a year later we would be here discussing this specific topic, having endured such tremendous loss. NATS and its partners are grateful for the trust you've placed in us over the past year as we've navigated the pandemic. Thank you so much. We've laughed, we've cried, we have mourned, we have learned, and we have grown personally and professionally, and we've persevered. Most importantly, we've done all of this together as a supportive community, seeking to harness the power of our collective to bring the best thought and science to bear on the challenges before us. We still have further to travel along this pandemic journey, but hope is beginning to dawn as vaccination rates rise and we plan for reopenings of our communities and businesses. We encourage you to remain vigilant and follow guidelines put in place for you to teach and perform safely, and remain aware of the statistics in your communities and your personal risk factors so that you can plan for a safe return to a post-pandemic teaching environment. We'll continue to bring you the best resources available in the coming days. You can always reach out to us by emailing questions or concerns you have to info@nats.org. During this year, despite the challenging and the challenges that we faced, we're celebrating that over 15,000 singers participated in NATS student auditions in a virtual environment. Although we recently announced that our summer workshop and national student auditions will remain virtual this summer, we have managed to prepare carefully constructed live experiences for the limited number of participants selected for the NATS intern program this summer. And that marks our first effort to return gradually to live face-to-face events within the NATS community. Our leadership at all levels is planning for a hopeful return to more live face-to-face events and activities in the fall of 2021 and into 2022. And we'll remain committed to science and safety first and foremost. If you're not a member of the National Association of Teachers of Singing, I hope you will visit us at www.nats.org and find out more about joining this professional community of voice professionals and to discover more about all the events I just mentioned. So our topic today, from asymptomatic cases to what is now classified as long COVID, the impacts of COVID-19 on singers are wide-ranging and potentially career-threatening. As teachers of singing, it is important to be an effective part of a care team for our singers who study with us. I am pleased to be joined by NATS Vocal Wellness Coordinator and co-author of The Vocal Athlete, Dr. Wendy LeBorgne, to discuss our topic today, as well as voice teacher and voice consultant at Breathe Well Physio Dr. Rachel Goldenberg, as we talk about being informed practitioners as we best serve our clients and students as they seek to return to performing arts careers. Wendy's a sought-after voice pathologist, speaker, author, clinician who's been clinical director of 2 different voice centers. Rachel also teaches voice and voice pedagogy at Ambrose University and maintains an active private studio in her native Calgary. Thank you for joining us, Wendy and Rachel. And we're going to start out today with Rachel talking. First of all, tell us how you are personally doing and working with your clients, and what modes are you working with them right now?
Well, thank you for having me today. This is quite an honor and a pleasure to talk about this. I began my journey teaching people with lung disease about 10 years ago when I was doing my doctoral dissertation at Shenandoah University in vocal pedagogy. And at the time, I was introduced to a woman with cystic fibrosis who sings. And her doctors were theorizing that she should continue her singing in order to maintain her lung function. And I thought, well, isn't that an interesting thing? I wonder why. And so I started researching the parallels between physiotherapy, respiratory physiotherapy, airway clearance, and voice physiology. And what I found was that what I was reading in respiratory physiology and airway clearance very closely paralleled what I was reading in the vocal pedagogy literature. And so I wrote a dissertation about the use of singing lessons as an adjunctive airway clearance technique for adults with cystic fibrosis. And I've been lucky enough to be able to continue that work at Breathe Well Physio with my physiotherapist colleague, Jessica DeMars. Together, we founded a program called Breathe, Sing, Move, which we actually talked about at the NATS conference this last summer. So if you're inclined to go and review that presentation, but we use our program. We teach singing to people who are living with lung disease, both obstructive and restrictive, so COPD, pulmonary fibrosis. And we team teach that. So there's an exercise component, there's a breathing component, and then there's the singing component. And as COVID has progressed, we are getting more and more referrals now from people who are experiencing these long COVID symptoms. And so we've been pivoting and doing quite a bit of work with them. And then as that work has progressed, I've had more and more calls from singers who are living with long COVID symptoms, and they're looking for some help with getting back into their singing. And I'm happy to be able to bring my perspective from the physiotherapy, respiratory world and marry that with what we know about singing.
Are you doing all your work remotely right now with singers and others?
Yeah, we're pretty restricted here in Canada. Our case count, we've been very lucky, has been relatively low. But yeah, everything I have done is remote. So we pivoted very quickly because by definition, our participants in our programs are high risk. And so very quickly we transitioned to online, and to great success. Actually, we had more success online and more participation online than we did live. And I think part of that was because people have oxygen tanks, or they don't respond well to the cold weather. I'm in Canada. So there were all sorts of factors. So we've actually done very well. That's been a bit of a silver lining for us.
Great. Wendy, how about you? What kind of modes have you been working in lately?
I am doing private practice exclusively at this point. So most of my clients have been remote. I have seen some in person, but not for singing. So I will do some hands-on manual therapy, both myofascial release, laryngally, and then some upper thoracic myofascial release, where we can both be masked. And that has been safe in what we're doing. But the majority of any singing work that we do has been remote. My clients range anywhere from some of my Broadway performers just kind of getting back on the horse here. It's been a long year, and this is multifactorial in not just voice. There's the psychological aspect of this. There is the emotional aspect. There is the breath aspect. Exactly. So as we think about COVID long haul, and we're taking a look at some of this, my artists have been really impacted.
Great. Well, Rachel's going to talk to us a little bit for a few minutes, and then we're going to come back to Wendy. She's going to talk a little while. We'll take some questions. Please feel free to put your questions in the chat on the side of the page, and we'll get those questions. We'll pepper them in as we can, and I think you'll find that we'll do everything we can to answer as many questions as possible today.
Okay, so I'll go ahead and just share my screen. There we go. Is everything good there?
Yep.
Great. So I'm Rachel Goldenberg, and I teach in Calgary, Canada, as I mentioned, through a physiotherapy practice called Breathe Well Physio. I've already introduced myself a little bit, but I think it's important to emphasize that I am not a healthcare professional. I am not a doctor. I'm not a physiotherapist. I'm not a speech pathologist. I am a well-educated voice teacher who has a lot of background and experience in this particular niche of teaching. And there you see me working with a Breathe, Sing, Move class. And I'm very lucky that I can operate with a multidisciplinary team. I don't operate in a bubble, and that's especially important given that I am working with people who are experiencing disease, and I'm using the singing with a particular pedagogical goal. And I'm very lucky that, when I'm working with some of these patients, I actually have the physiotherapist often, if not in the room as in olden times, but now on the Zoom call, and I can always defer, and I have a safety net. So I think it's important to just acknowledge that we can't really exist in a vacuum, and it's very important to have a team that you can rely on. So today I'm going to translate a little bit of what's out there about long COVID. And ultimately, what I think we'll see is that we have more questions than we have answers. We don't really know what this is. We are in the stage of long COVID that we were with acute COVID this time last year. If you remember, there was real panic. Nobody really knew what this virus was or how it was going to manifest. We were writing out our wills. We didn't know if it was the end of the world, and now we've come to a point where we know much more about it. We still have much farther to go in terms of our understanding. But long COVID is really in that place of what is happening. We're not sure who has this, who has something else. Right now, we are lacking a robust definition. But the working definition is the presence of signs and symptoms that continue for 12 weeks after the initial diagnosis. And it's important to understand that these signs and symptoms should not be you cannot explain them by an alternative diagnosis. And it's difficult to distinguish long COVID from a lot of other things going on because we have people who may have had pre-existing conditions. A lot of the symptoms of anxiety in general mimic what's going on with long COVID. And we are in a very anxious time. We are in a traumatic time. This is, we are all experiencing this. We should be in bed with cookies for sure. So it's hard to distinguish what is the anxiety and what is actually the result of having had the virus. Access to services can be limited for a number of people. So really defining how many people are experiencing this is difficult. We have cases where people are going to their general practitioners and being turned away, being told, no, it must be anxiety that you're experiencing because there's nothing, quote unquote, really visibly, quote unquote, wrong with you. But the thing is it's not right. And so we're still trying to figure out what that might be. And then there's the stigma disbelief, from other people. And so we're fighting a lot of fronts here in terms of figuring out what exactly long COVID is. There are 3 phases that's helpful to be aware of. So we have the acute phase. That's when you go and get your swab and you have a positive result and you are now isolated for 2 weeks because you were contagious. So that's the first 2 weeks. After that, you may experience cough, fatigue, mucus, just ongoing symptoms. And, you've probably experienced this in the past with other nasty viruses. It's not uncommon to have cough, 6-8 weeks later, and you're like, oh man, I'm still coughing. That happens. It's when it's going on past the 12 weeks that now it's more chronic. And, that term chronic really, it would be nice if we could get rid of it, but that's the way it's described. But it's in this case, because we don't really know what's going on. We don't know if it's going to last a year, if this is a few weeks out, I prefer to use the term recovery time, the healing journey. But for medical purposes, we'll talk about it as the chronic phase. So here we might be experiencing ongoing symptoms for sure. I've highlighted in blue 3 things that I'm going to talk about in a moment. The dysautonomia, breathing pattern disorders, and post-exertional malaise. People experience in the chronic phase report extreme fatigue, sensory disturbance, sleep disturbance, the inability to return to baseline. And Wendy's going to talk about this too, about how singers, both her vocal athletes, the elite athletes, and then singing teachers are reporting that it's really difficult to find where they were prior to having COVID in terms of their vocal abilities. And then we have cognitive difficulties, the so-called brain fog, excuse me, that a lot of people are reporting. So because we don't really have a robust definition of long COVID or really a lot of data, we're sort of looking at parallel conditions that we might use for guidance. And one of the conditions that we are using right now is the myalgic encephalomyelitis, MECFS. It's much easier to say MECFS. You can use myalgic encephalomyelitis as a tongue twister if you'd like in your vocalises. But this is basically chronic fatigue syndrome. And it's defined as fatigue is beyond what is expected. So if, for example, you get up, you give a concert, you're going to be tired afterward and you might sleep in the next day. But then you can return to your regular activity. In chronic fatigue, this might take you out for a week or more in some cases. So it's beyond the expectation, okay? And we're seeing that quite a bit with long COVID. And so when we are teaching people to manage their long COVID symptoms, we're looking to MECFS for guidance. When we talk about this, it's going to be helpful to know a little bit about the autonomic nervous system. Now, this is a branch of your nervous system that is responsible for your unconscious bodily functions. So things like your blood pressure or the dilation of your bronchial tubes, things you don't think about, your digestion. And thank goodness we don't have to think about that because we would be exhausted, if we had to juggle all of that. So these things happen automatically. So the autonomic nervous system is divided into 2 branches, and some people argue, well, there's actually a third, but we're not talking about that today. So there's the parasympathetic nervous system and there's the sympathetic nervous system. So the parasympathetic nervous system is your rest, digest, and repair side. And this is where you feel calm and relaxed. It's responsible for decreasing the breathing rate, the heart rate, your blood pressure. And on the other side, you have the sympathetic nervous system. And it's a bit of a tricky name because people think, oh, sympathetic, that's the nice one, or quote unquote nice one. It's a very important side. But it's the sympathetic nervous system is responsible for your fight or flight reactions. This is your alertness, the tension, the panic that you might feel, increased breathing rate, heart rate, blood pressure. And under normal circumstances, these are in balance. They create a bit of a yin and yang. One is operating the other at one time and balanced out by the other. And this is very important for our living circumstances, a term called homeostasis. And what we see in long COVID is this dysautonomia, that we end up having inappropriate responses from either side of the autonomic nervous system. So we might see things like racing heart when you're resting, or increased blood pressure at rest, breathlessness. Now, all of these things would be normal if you were exercising. Your heart rate should go up. You should feel breathless. Your blood pressure should increase when you're exercising, and then it comes back down to baseline. That's that balance. But we're missing that. So, for example, I have a lady who, when she's sitting down reading a book, her heart rate will spike to 120 beats per minute. This is part of that dysautonomia. One of the things that occurs when we've had a respiratory infection or we're dealing with lung disease is a breathing pattern disorder. We start to breathe in an inefficient way or in a way that makes us feel like we're getting more air in, but it's not exactly helpful. So here in the diagram, you can see on the right-hand side, an arrow pointing up. So that's that apical breath up and down, or what we refer to in some pedagogy as clavicular breathing, right? And then we have the check mark over the, okay, well, let's allow the ribs to swing, the diaphragm to descend, right? So typically with lung disease, we see people going for that more clavicular breath. If you remember from your vocal pedagogy classes, you actually take in more air when you breathe through the rib cage because there's a greater volume increase. But the thing is the rib cage is very, very heavy, and I'll talk about that in a moment. And it's not very efficient. Definitely here I'm talking about regular breathing. I'm not talking about breathing for singing. This is quiet breathing when you're not thinking about it. You're on the couch, you're eating your chips. You know, this is your quiet, regular life breath. One of the problems with overbreathing when we take in too much air is that this throws off our oxygen and carbon dioxide balance, and that's really important for our bodily functions. It can change our pH, and so the chemical reactions that have to happen in our body can't happen well because we've thrown off that balance. So even though intuitively we want to take in more oxygen, it's actually much more complicated than that. So overbreathing can lead to problems. Common symptoms of that, which you might come across in your own studio, you might see somebody who's yawning or sighing or having disturbed sleep or anxiety. You know, if you're sitting there now, and I'm not necessarily recommending that you do this because this wouldn't be appropriate for everybody, but if you were to take 20 rapid shallow breaths just as you're sitting there, you know, you'll probably not feel too good afterward. You might actually literally feel anxious. People report nausea, clammy hands, that's a sympathetic response, that fight or flight, fatigue. As I said, it's very inefficient. Muscle aches, irritability, air hunger is also a symptom of that. That's that feeling of I can't take in enough air, right? And that largely comes from the balance of carbon dioxide and oxygen. Now, those things in themselves are not necessarily problematic, but if you have somebody in your studio that is coming in and has breathing discomfort or an erratic heartbeat or chest pains or dizzy spells, extreme hoarseness that doesn't improve, or rapid shallow breathing that doesn't improve, those are red flags, and they might either need to be addressed immediately, in which case you might have to call 911, or they can, you know, let's rest and see what's going on, and then you should bring this up with your doctor. But if you are ever in doubt, do not hesitate to consult with a medical professional and leave that decision-making about what's to be done to somebody with the proper training. Don't take that on yourself and don't feel like you have to. So just a few more words about diaphragmatic versus chest movement. As I said, the ribcage is very heavy. At any given moment, to lift the ribcage, excuse me, it takes about 30%. Takes about 30% of your body's energy at any given moment to lift it. So this is quite a bit of work. And as we know, the neck muscles are very tiny and they get tired. So we see people with very tight necks, very tight shoulders. We see unexplained weight loss in some cases, not all cases, and I don't advocate this as a weight loss method, but that's from that chest breathing. It's tiring, really exhausting, versus diaphragmatic breathing, which only requires about 5% of the body's energy. So that's very efficient, and just, the contraction of the diaphragm and elastic recoil, it's much more efficient and much easier on the body. So in terms of breathing pattern, what we're looking for is a short inhale followed by a longer exhale and then a pause. So you in, blow it out, pause, and then take it in. Blow it out, pause, rinse and repeat. We're looking for about 8 to 12 breaths per minute. Some of the literature says 12 to 15 breaths. It varies, but we tend to advocate for longer, slower breaths, especially with lung disease. We want all of the air to be pushed out. Okay. So moving on to this concept that you might run into in the NATSChats literature. Post-exertional malaise. This is a flare of symptoms after exertion, and it may appear 24 hours or longer after the triggering event. So given that time frame, you may or may not remember what the triggering event was. It can be from physical activity, from cognitive overexertion, or sensory overload. So all of these are things that can cause a crash. And I think it's worth it to talk here about how singing is inherently athletic. If you think about what we do, it is an extension of an exaggeration. It's, we're doing cultured screaming, we're doing all kinds of things. There's a physicality involved to singing. We breathe to larger lung volumes, that's been documented. We engage the body in a much more athletic way. We coordinate our breath, our voice, and our articulators. And we require a lot of stamina. There is serious physicality involved, and then you combine that with the sophisticated cognitive tasks that are required for singing. We're operating in foreign languages. We might have dramatic characters to portray. We're interacting with other musicians. And we might be playing other instruments. There's a lot going on. I had a lady who was doing a gig, and she was standing, she was playing her guitar, playing the harmonica, and singing. This led to a crash. And you wonder, when you look at that, like, yeah, wow, that was a lot. That was really quite complicated. So we can talk about graded exercise. And this is something that is how you build your return to your baseline in a traditional sense, right? So I've had bronchitis and now I'm out of bed and I'm going to go for a walk because I'm feeling pretty good. And then the next day, hey, I think I can go for a run. I'm going to just go, just a short one. And then within a few weeks, you can build up to wherever you were before. In terms of voice, I'm just going to vocalize a little bit. Okay, now I'm going to try a song. And now I'm going to try an aria. And now I'm back to performing in my opera. Graded exercise works in many cases for many things. But in terms of what we see in our guidance condition, MECFS, graded exercise does not address the metabolic changes and the atypical reactions to activity that lead to symptoms in people with MECFS. And it follows that programs that gradually increase exercise may do more harm than good. And I think what we're going to see when we think about how we're dealing with singing in terms of our return to baseline, we're going to see from Wendy that people are not able to find their baseline. And we as a profession are characterized by people who are driven, who want to work hard, who want to push. That's in our nature. And here, that might not be what works for us. And we have to be careful about how we're using singing in either in an individual setting or in a group setting as a therapy. We have to be very careful about how much exertion we are placing on our singers, because ultimately that might actually cause setbacks. So I'd like to introduce this concept of pacing, which is, we should be familiar with this in some cases, but this is the self-management strategy for activity. Basically, you're active when you're able, and then you rest when you're tired. So I've got a guy going upstairs here, and let's say you look at the stairs and you're like, God, that's really far. Okay, so let's take 5 stairs and then we're going to rest for a minute. And then we're going to do another 5 stairs and we're going to rest for a minute, right? So we're going to pace it and see what works. Maybe a minute is we're okay, so maybe we can reduce it. It's very much trial and error. But we have to take the concept of we do our activity and then rest. And because this is NATS, I used a quarter rest. I hope there are groans out there. I can't see you, so I have no idea. So let's talk about rest. Rest as much as possible before a triggering event. And what the triggering event is going to vary person to person. So for some people that is, I'm going to vocalize. For some people that is, I'm going to give a concert. For some people that's, I'm going to have a lesson. For some people that's, I'm going to get out of bed. It will vary. We have a wide range of long COVID as much as we have a wide range of acute COVID. So really listen to your body, rest before the triggering event, whatever that triggering event may be. This concept of doing less is doing more is going to be so hard. We are a culture of achievers. We do not value rest. In fact, we value people who push hard. And we see people that are resting, frankly, as lazy. But we need to change our mindset on that. We need to give ourselves permission to take the time that we need. And one of the best descriptions of this that I've heard from another physio was, okay, so I was a marathoner before I had COVID, and I feel like now I can go out and run 5 miles. Well, instead of running 5 miles, I'm going to run 1. So whatever you think you can do less until you know that that's not going to trigger a crash. So if you feel like you can vocalize for an hour, try 15 minutes or 10 minutes or 5 minutes. Play around with it, see what works. But remember that the crash can happen many days later. So this is going to be a process. Set small, manageable, and obtainable goals. If you have an opera performance 9 months from now, you might want to rethink that to, okay, in 9 months, I might perform an aria, right? Because that might be a much more attainable goal than something that's quite so grand. And then prioritize those goals. I have small children, and they are still going to get up and bounce around regardless of how I'm feeling. And so my priority is going to have to shift. And we teachers are going to have to guide and support our students as they are trying to prioritize what is achievable for them given the circumstances. A journal can be a very useful thing to keep track of what works and what doesn't work. Again, the triggering event can happen a very long time before the actual crash. Wendy will talk a little bit about wearables as well. And I'm talking about like a heart rate monitor. A healthcare provider can tell you where a certain threshold is, and you want to keep that heart rate below there. So if during your lesson with a student, their heart rate starts to go above that threshold or approach that threshold, that might be a good indication that now is the time to stop and let's just take a break and see if we can come back, or let's end the lesson now. So how can we best support our students at this point? Well, honestly, listen to your students. They are having they can be having a really rough time with this. It's not just a physical thing, but it's also a question of identity. Can I actually continue doing this, right? And there's a lot to get to sort of unpack. And those strong relationships that we build with our students put us in a place of trust. So really listen to your students. Believe them when they say that they're too tired. They very well may be, and advocate for them. If they're being turned away by their general practitioner or their family physician, or even some specialists, they might need you to say, well, look, I've seen this pattern happening with you. I think you need to have this addressed, and here's the name of someone else that I think can help you. My job, given my role within the physio clinic, is to really reinforce and support the treatment plans from the health professionals. Very often the respiratory patients come to me for some voice work after they've worked with my physio partner. And so I can say things like, so what did Jessica tell you about your breathing, and how is that working for you? And how are you connecting that with your voice? So building that bridge is really helpful, being another point of view. Ultimately, go slowly and be prepared for a lot of ups and downs. A lot of this is trial and error because we don't know how far is too far. Be prepared for 2 steps forward and 4 steps backward. It can work that way. Some strategies for adaptation in your studio: shorter lessons, 2 half-hour lessons, 4 15-minute lessons in some cases. Have the students sit down. That can be really great, especially if you're worried about falls or drops in blood pressure. Whatever the warm-up time is, double it. Expect it's just going to take longer. Adjust the breath so that you're not breathing to such extreme volumes. Keep it simple, okay? So take more frequent, smaller breaths. Sing within a reduced range. Now is not the time to take out your Queen of the Night and Zarastro. Okay, keep it simple, keep it small to begin with. You might consider slowing down the tempo. Sing slower pieces. That will allow you to breathe better. Now is a great time to revisit your easier repertoire. Sing folk songs, for example, is a great way to ease back in. Be aware of sensory overload. Just the sounds sometimes can be overstimulating. So, if you've got lights and you've got, a whole orchestra behind you, that could be a lot. Now is a great time to remind your students about good vocal hygiene. And this isn't just for your studio students. This is for anybody who's coming to you for a little bit of retraining, like, can you help me improve my speaking voice a little bit as I'm recovering? Vocal hygiene is a great thing to talk about. Hydration, rest, et cetera, et cetera. Be sure that you're checking in about the last session. How did it go? Did you feel like it was too much? What is working? Inquire about the crashes. And then as the lesson is going, check in about the energy levels. How are you doing? Do we need to stop? Should we keep going? How are you managing? And then this is really important because we talk a lot about vocal cool downs, but we don't necessarily talk about breathing cool downs. That if you've been breathing to larger lung volumes, it can be very helpful to, let's just find our baseline again, so that we're not continuing those large breaths that we use in singing when we're just sitting and watching Netflix. So again, go slowly. Give yourself and your student permission to be flexible in setting your goals. Flexibility is your resilience right now. That's the way through. And when in doubt, refer out, look for support in your medical and allied health community. And then other singing teachers. It's very often that we that I receive referrals from other singing teachers whose students have had issues. I operate as a singing voice specialist. And so they'll come to me for 2 or 3 sessions. Sometimes the teacher can be on the Zoom call. That makes it very easy, or in the olden times within the studio. So there are knowledgeable people around, and don't feel like you have to take on the burden of knowing everything. Lastly, It is so important that you teach the person in front of you. We are typically very sensitive to our students' needs, but everybody is experiencing this in a different way. So be sensitive to that. You might be expecting a crash and then it doesn't happen, or you might not be expecting and then that does happen. So really, it's the person in front of you, and you use your best instincts as a teacher to help that person. I'll leave you with some resources. Breathe Well Physio is the practice that I work at. The musical Breath is the brainchild of my colleague in the UK, Feeney Cave. She has wonderful resources for anybody who's interested in pursuing singing for lung health. And then there are some physio sites there. Long COVID Physio is wonderful, and physios for ME. They're maybe less accessible. They're definitely resources specifically for health professionals, but you can find things there. And then the Body Politic is an advocacy group. So thank you very much for letting me yak at you for this time. And I will pass it over to Wendy.
There we go. We are now unmuted. The joys of live events. Allen, I don't know if you can share my slides. I'm in a place where I'm not actually able to do that right now, so he's going to work on that for just a second. Or if you had any questions, perfect. Thank you, Allen. This. To me today, this is I'm not going to lie, this is actually a fairly challenging day. It was exactly 1 year ago today that Broadway shut down. And I happened to have artists on this very last tour that closed on March 15th. So we have a couple of more days. And I remember this day a year ago, when we sat there and we talked to each other and we just said, what do you think's going to happen? I don't know. What do you think's going to happen? And it was so beyond anything any of us, I think, could have expected. I think and so much, as we all know, has happened in the world in the last year, beyond the theater world, and art reflects society, especially in the States. So I'm excited to look forward towards the next 6 months. I can tell you that I feel like there is some light at the end of the tunnel from what I am hearing on the side of things, from the professional side of things. We are moving in a forward direction, albeit slowly. Things, obviously, the vaccinations are starting to roll out. And if I, as a health professional, can say, I would encourage you to get vaccinated if you can. So a few months ago, and some of you may be familiar with this data, I did a little bit of a research reach out for professional voice users to say, if you tested positive, if you thought you had COVID, what's going on? What were your symptoms? So this is a little bit of an overview of that. And then we're going to dive into, okay, great. Now what do I do with these folks? And then I'm going to bring in a little bit of a study that Allen and I are working on. The data has been, I actually looked at it last night, Allen. We have had 90 participants. That data is not included here because it is scheduled to be presented in June. And so I won't tell you all of it, but I'll maybe give you a little teasers. So when we look at our elite professionals, and these are our elite vocal athletes who are either on Broadway, off Broadway, tours, or cruise ships, it shouldn't be surprising that when I did this study between March and June of last year, that the majority of them lived in this 25 to 34 age range. What I will tell you is the survey that we sent out to NATS, that Allen and I sent out to NATS, shows a different demographic. What it does take a look at, which I think when this comes out in June will be exciting to see, is it's going to look more at that 35 to 64 age range of people who reported COVID or COVID symptoms. In this particular study that we did, the majority of them were female. So you can go ahead and advance to that next slide. And the new study not surprisingly, it is reflective of the NATS teaching population, and the majority of respondents were also female. Moving forward, when we looked at that initial, and I know this is super tiny, sorry, but when we looked at that initial demographic of where the reported infections were, remember that I was looking at this in March of last year. And so the majority of the time, those folks were actually getting that, most of them in New York City, or it could have been part of the demographic of the population that I see, which is elite vocal athletes who are generally in major cities. As we look at this over time, just like the rest of our country and across the world, because we now have from all over the world some data, what it looks like. This is when they reported the initial date of onset. And as you can see, this was March 1st to March 31st a year ago. When Allen and I get ready to present our data, just like what we saw in this country, we end up seeing a second spike in the late fall and winter of the end of 2020 into early 2021 that mimics. We see this spike in March, then we're going to see this other spike of people getting it with our singers. So go ahead and move forward with this, please. Interestingly, early on, you have to remember that most people weren't able to get tests. Now tests are much more readily available. I have also had more people than I can count who initially tested negative and then ultimately either tested positive or tested positive for antibodies. So I have kind of said to my artists, if it looks like a duck and it smells like a duck and it walks like a duck, let's assume that it might be a duck. So when we look forward in time now, and for you who may have answered this second questionnaire that we sent out, thank you very much for your time and energy, but we have to take a look at this moving forward. Rachel alluded a little bit to this idea of acute versus chronic and defining that. So if we look forward at the next slide, one of the things that has been so interesting and unique about COVID is that you end up with a group of people who are essentially non-symptomatic. For us singing teachers, oftentimes that may be these young, I say young kids, but so often they were asymptomatic and going about their lives and they really didn't have any symptoms. And we see lots of physical athletes who are going out and playing entire basketball games or football games. I mean, ultimately that stopped when they started more frequent testing, but there was a period of time where we had a lot of non-symptomatic physical athletes. One of the studies I've read recently is some of these athletes, physical athletes who have had COVID, who were essentially non-symptomatic or mildly symptomatic, about 30% of them, 30% have cellular level cardiac changes. To me, that's a very high number. You get the total polar opposite, where we've had some vocal athletes like Nick Cordero, who lost his life to COVID. And again, this is not news to anyone here, but he was a healthy, fit person prior to his diagnosis. And then you have these people in the middle. We're going to look at an interview here in just a second from this artist. He is not one of my personal artists, but I had watched this interview and think it's pertinent. But he ends up in this class of these long COVID patients. So let's go ahead and look at an interview that was aired on Nightline in June of 2020. Allen, you're going to need to turn yours to share the sound on that. And if for some reason this doesn't work, while he's working on this for just a second, you know, one of the things that we are going to see in these COVID long haulers, and if you can't get the sound to work, that is okay. I will be able, I mean, I can point people in a direction where they can go back and look at this interview. But the fact of the matter is this is not linear. We are not seeing typical progress. We are not seeing the progress that we would anticipate with people that are in really good vocal shape before COVID hit them, even if they only have mild symptoms. Oh, we are not getting sound. So we're going to go ahead and move through. To give you in a little, and I'll go ahead and share this link with Allen so that he has it, so that they could maybe put a link in there. So if anybody wanted to go back and look at this interview, I think this artist explains very well the fact that he has good days and bad days. And his bad days are characterized by coughing, mucus, breathlessness, where he thinks he's almost better. And then he feels like he goes way back to the beginning. And that is psychologically detrimental, and that's physically detrimental. And Rachel talked about these triggering events in his interview. At least he doesn't explain what his triggering events are, but I see this in my artists as well. That is continuing out now almost at a year. To give you an idea of what you're looking at here, the blue is what people experienced before how they rated themselves physically and vocally, fitness-wise, before COVID, and then after COVID. The physical fitness went from 68% to 53% pre to post. No single singer have I ever met rates their voice as 100%. At 100% vocal fitness level, certainly not when they're doing 8 shows a week. So if they're rating themselves at 77%, I feel pretty good about that. But it dropped down to 57% after COVID. Interestingly, when we look at our teachers, we are seeing very similar findings, almost identical to what we have here. So I'll be interested to report that data and parallel that. Going forward into the slides as to what we're seeing as what people reported most commonly. Again, the blue is in the acute phase of COVID, what they saw. And then the orange is after they were out of the acute phase and into the chronic phase. What's really important for you to sort of note, during the acute phase, this is exactly what you'd expect. What we see is a lot of people have chills, fever, body ache, headache, feeling crappy. What lingers? All of those things go away. What lingers most is respiratory symptoms and voice symptoms at 28 and 26% respectively. Okay, those are the number 1 and 2 things that after COVID acute is gone, that is what remains. I can tell you, just as a little lean in, as a little teaser, we're seeing almost identical things with our singing voice teachers. And we're seeing it with additional populations that are not singers as well. Go ahead and move forward here. And then this is actually not surprising to anyone, but if when we asked singers, when we asked these elite vocal athletes what their biggest concerns were for returning beyond COVID, and this is not related to the psychological aspect of things. This is not related to, is it safe? This is talking more physical symptoms. Vocal fatigue, power in their voice, dynamic control, physical fatigue, and breath support were the top ones that we're looking at here. And I think any of us who teach singing, this is not shocking that these things all go hand in hand. If you are not physically strong and your breath is not under you, your voice will very likely fatigue, because if you are compromised in one of the 3 subsystems of voice, you will compensate in the other 2. Moving forward here. So how do we return to performance? Mentally, physically, emotionally, vocally? There's not a roadmap for this. What I can tell you, what I've seen with my patients, is that if we go forward here, Allen, that it is unique to each individual. And like Rachel said, there's still more we don't know than what we do. So when I have worked with my post-COVID vocal athletes, I take into account the knowledge that I have based off of laryngeal anatomy and physiology and function. I look at what I know related to respiratory training. I look at historically vocal pedagogy. How do I take a singer from beginning to advanced in their voice? And we start there. It has not been linear, though. I can tell you that this has not been the straight up path. It has had jaggedness along the way with almost every single one of my vocal athletes. So let's take a step forward and talk about rebuilding physical stamina first. Before any of you, and if you advance one there, Allen, if you, before you really start working with a singer, and I have a slide here that at the end that gives you a red light, a yellow light, and a green light. So you can start thinking, oh my gosh, I don't want singing teachers coming away from this feeling one of two directions. People are either going to decide after this webinar that they have their Google MD degree and they're good to go and they can treat all of their singers, or they can work with all of their singers, or they're going to be so terrified to potentially work with COVID patients post-virus that you don't want to work with them at all. I'm going to say, you've been a singing teacher for a long time, most of you. Trust your ears. Trust what your singers are telling you. And when in doubt, refer out. So listen to, as a patient, listen to the medical doctor. If you are a teacher and you are not sure if the singer should be back in your studio, I think getting consent from a physician to say, yes, you are safe is appropriate. I will tell you that I have had multiple singers that have had medical clearance to go ahead and start retraining the voice. They walk into the studio and within 15 minutes, we need to stop the lesson because they cannot vocally and physically do what I'm asking them to do. And so, how do I say this? The diseases that we treat do not always read the textbooks that we have. So they don't always know how they're supposed to act. And especially in COVID, when we're still learning so much about how this disease affects the body, there is no playbook. There's no cookbook solution to all of this, I guess I should say. As Rachel's already has alluded to, slow and steady, taking periods of rest. Rest is huge. If you study for a test right before you go to bed, if you practice a dance routine in your brain of, oh my gosh, this is a footwork I need to do right before you go to bed, we know that resting, when the brain rests, it assimilates the neuromotor patterns to execute what you are wanting it to do. As we recover from COVID, as our singers recover from COVID, physically and vocally, short, frequent practice sessions for me have been much more beneficial for the clients and my patients than an hour session. Sometimes it's just not doable. When we talk about respiratory strength now and rebuilding, first and foremost, I have 24 years as a clinical voice pathologist. So I do respiratory training with appropriate candidates. And I feel fairly knowledgeable about this. But with my post-COVID patients, I'm not even really thinking much about doing this until I have clearance from either a pulmonologist or a respiratory therapist. For those of you who are not familiar with this, on the top left corner is called an inspiratory muscle strength trainer. It is a calibrated device loaded with spring so that we can provide resistance training. So it trains the muscles, the one on the top left trains the muscles of inspiration. So we get all of those inspiratory muscles, it isolates them out in the absence of sound production because we're not doing it in conjunction with sound. The one on the right is called an EMST 150. That's an expiratory muscle strength trainer. It is also a calibrated device where we are doing expiratory muscle strength training. So for me, this is like going to the gym for your respiratory muscles. This is not designed to take a breath in and voice, that is a different exercise. These are strength training and isolating out inspiratory and expiratory muscles for respiration. I know we all know this, but I just say it out loud that your lungs are passive. You need active muscles to be able to get air in and out of your lungs. These are skeletal muscles, so they do respond to performance training like other skeletal muscles. You need to do them correctly. You need to know what you're doing. When I train people on these devices, we're doing something called, before we engage in the training program, we'll take things called minimum and maximum expiratory pressures so that we can set these devices appropriately for the patients. Blowing through straws, spirometry, those are different. They are not resistance devices calibrated in the same way that these are. I do know, I think I read just very, very recently, the EMST company that makes EMST 150 has recently, because 150 is how much back pressure, they've actually recently reduced it. And I know there's a new one that just came out that's the EMST 75, I believe, so that it has to reduce the resistance because aside funny story, I bought an inspiratory trainer for myself a long time ago, and I'm a fairly fit person. So I bought one for active people. Yeah, I could not even do the lowest level. I had to get like the remedial inspiratory trainer to start with before I graduated up. These are harder than they look when you do them correctly. So baby steps. And if you are not comfortable with this, again, I think we need, when in doubt, refer out. The one beauty of COVID is that I get to see people all over the country and internationally now, because if people don't have the expertise in that one little area, there is access. So Rachel and I are both happy to help you with that. All right, so looking forward, vocally within a lesson, we need to think about training strength, stamina, flexibility, and agility within the instrument. This is my buddy, Pat Linhart, who's a voice professor at CCM. We do half marathons. When you look at a half marathon training program, it is gradual build, plateau, gradual build, plateau. You're also going to notice a lot of cross training in there. So you want to think about cross training the voice in lessons for short periods of time, so it allows you to have greater longevity. So we might work head voice for 2 minutes. Then we work chest voice for 2 minutes. Then I might work a mixie belt for 2 minutes. Then I'm going to come back to do an agility exercise where we might do, hey, yeah, we might do a little riff so that we do a little agility for 2 minutes. Then we're going to go back to head voice, versus the singer coming in and telling me the power of my power belt is not back. And you as a teacher want to work power belt exercises to help them get that back. It is likely going to fatigue them very quickly. So cross training when we do this. Okay. And then Alan, let's go ahead and move forward here. Things you thought you would never need in the voice studio. How many of you, when you thought you started teaching, thought, oh, I need to buy a pulse oximeter along with my piano or keyboard? This is a finger pulse oximeter. The number on the top, for those of you who don't have one or haven't seen one, is the percentage of oxygen, and the one on the bottom is your pulse rate, or the beats per minute. That's what BPM stands for. You can get these most of the time at your local drugstore, or you can order them on Amazon or something like that. Most of the time under $20. You do not need to spend $1 bazillion on these. They're battery operated. You put them on your finger. They can be something you have in your studio. I'm not doing any studio in lesson right now. But my singers can get these as well. So going forward, it's all fine and dandy that you have a pulse oximeter, but what do the numbers mean? In general, the average population numbers are somewhere between 95 and 100%, meaning the red blood cells are fairly well oxygenated. 91 to 94% is kind of falling below. And if it's less than 90%, oftentimes you would want them to consult their doctors. one of the things you need to know about this is that some people with lung disease already could function at a lower level. They can function at that 90 to 90% level. But if you're seeing your singers down there, getting it checked out is good. So it's something that they can wear. You know, the other thing that we have taken a look at recently is heart rate monitors. Like I have a watch that tells me mine. Oops, go back for just a second, Alan. Thanks. But there are heart rate monitors that you can have just on your phone or an iPad, or the one on the left is an Android, the #1 rated Android heart rate monitor. The one on the right is the one for iPhone. And again, I'm not endorsing any of these products. I don't get any kickback from anything here, but all you need on the phone is actually your camera and your thumb. That's how they measure your heart rate, and they're pretty darn accurate. So if anybody even just has a phone at their home, that's important to know. Normative data as it relates to heart rate monitors, or what your heart rate should be. On the next slide, I have some links to like a heart rate calculator, and it's basing it on your age, your height, your BMI. You can click that link and you can type in your numbers or your students' numbers. They can type it in, and you have a general idea of where they should be. And then the American Heart Association then talks about where maximum and minimum will be. Ideally, that heart rate calculator actually does tell you, that specific one does tell you with exercise and my age, because I did it earlier today, where my maximum heart rate should be. So you want to kind of pay attention to that when we go through. Okay, so you're going to need to click through this a little bit at a time, Alan. I'm sorry. So this is our red light, yellow light, green light. Just so that you have a few things to take away. Our green light items, where you can say, yeah, I feel good about this. This student is no longer contagious, meaning that they're generally 2 weeks out. They feel fine. They don't have any lingering symptoms of the virus. Their breathing has returned to normal. They're not doing much coughing or throat clearing. And I say that knowing that students like to clear their throats all the time as it is. And their voice is essentially normal for that singer. Our red lights, because we're going to go on this opposite end of the spectrum. Moderate to severe dyspnea, and dyspnea means shortness of breath. So anytime if they're either talking or singing and you're watching them really feel like they're laboring in their breathing, that might be a red light for you. If anytime they take a breath in, or they start to sing, they start coughing, that would be a trigger that we might want to stop doing what we're doing. If they get dizziness with voice use, or even just standing up, that would be a time where we say maybe singing is not the place we want to start. If their heart rate starts to get pretty rapid, if you have the opportunity to monitor it, if they have hoarseness, dysphonia that seems abnormal to you, or if they have rapid physical, vocal, or emotional fatigue with singing. If you have physical, vocal, or emotional fatigue after 30 minutes, that might be normal. If you're doing it after 2, that's an abnormal situation. Everything else falls in the yellow, and that's a lot of stuff. But I wanted to kind of give you a few anchors of here and here so that you can come away feeling like you have a few tools to think about. The other thing that Rachel and I talked about last night, and I think it's very important, I doubt many singers, you can go forward here, I doubt many singers have, or voice teachers have what we call an emergency plan. In my world as a health professional, when we are now doing telehealth or teletherapy, one of the things that needs to be included in working with clients for telehealth, some of the paperwork on the front side of things, is that I have an emergency plan in place. So if I am working with Rachel, I know Rachel's phone number, I know Rachel's address. So if Rachel had an abnormal physical event, a heart attack, a stroke, something, she passed out during our teletherapy visit, I, as a clinician, actually need to get off my call if I can, or have a separate phone handy that I can call an emergency line and say, I was on a session with a client, Rachel appeared to pass out. This is her address. This is her phone number. Please send somebody. So if you have any concerns, maybe don't be working with a patient. If you're concerned, that could happen. But I just think as we move forward in a Zoom world, knowing where your clients are and how to get them help should they need immediate help is not hard to do, and it's not a bad idea. And then I think we are at the place, Alan, where people can ask us questions, and I can't see all the questions in the chat, so I'm going to leave it to you to ask those as we go through.
Great. Thank you so much, both of you, for just laying out both aspects, not only what you're doing, but just how you're working with different populations and the kinds of people that we're having to, that are also coming to us for voice lessons, some of them. Yeah, we have a lot of questions, of course, as we might expect. And so I'll just kind of walk us through what we got here. I think one of the, you answered the thing about having a pulse oximeter and how that can help guide us in some of our lessons. Somebody asked, has eustachian tube dysfunction been seen at all with long COVID?
So in my world, what I have seen with some of my performers is they get weird hearing issues. That was actually not in my original questionnaire, but they're having tinnitus, where they're hearing ringing, and weird difficulties with pitches. And I've seen that. It's, again, I think if we think about a post-viral aspect of things, that doesn't surprise me. Rachel, what have you seen?
I haven't seen anything specifically within my own realm, but I have heard of other people in support groups having issues with sensitivity to sound. And that goes along with the dysautonomia, that there's some kind of neurological thing going on here. So, just being sensitive to that might be the name of the game for as you move forward, and who knows how long that might be. Unfortunately, we are in the business of creating sounds, so there's that balance to be had too.
Right. Somebody asked whether there's a list or database of group of the physicians and medical professionals that are treating long COVID that we can refer clients to. I do know, Rachel, go ahead. I think you were going to answer that.
Well, there are different long COVID clinics depending on where you are geographically. I will say that many of these clinics exist to rule out things like fibrosis or anything like serious, or myocarditis, or anything that's like life-threatening. But they don't necessarily involve physiotherapy or any kind of speech rehabilitation afterward. So that's where people are sort of left in the lurch, and this is really evolving. A lot of the medical professionals are still going, what is this? How do we deal with it? A lot of physiotherapists are saying, well, we're so used to prescribing exercise, we don't quite know how to deal with this. And so there's quite a bit of discussion, but there are many support groups around, and I listed those in my slides too, that will have lists of people who are interested in you, and you can reach out to them and they can help you make referrals. But I think if you're in doubt and you're looking for someone to help you, look to the long COVID clinics first, and then I'd say the next step is to reach out to the physiotherapists.
I believe when I was looking the other day on the Mount Sinai has a fairly large COVID center that they set up in New York. And I believe it was from there. There was a link to a list that some medical group is keeping of clinics around the country. But I do think it's important about what you mentioned, that they're not all going to be voice specific by any means. They're right at this point. They're just starting up, and they're, like you said, they're ahead of us because they know more than us. But there's still a lot that even they don't know. and they're the first to admit it. So also somebody asked, some of the singers I have worked with who don't identify as having long COVID have still lost suppleness in the torso that they need. Have you seen singers who don't have long COVID but have some of these changes?
Yeah, I mean, I can say that I have, I think I have 6 singers with, I wouldn't even say they have long COVID. They just are recovering for COVID and need to get back into performance. Honestly. So we do a lot of physical stretching because sometimes the act of singing itself is bringing, they seem to do well with mucus until we start singing, and then it brings it all up. And then it's like, oh my gosh, is this bad? Is this good? And for me, it's good. I need them to move this mucus, but we are doing lots. I'm doing lots of physical stretching with them. Oftentimes when we've got to get movement back in here. I feel like it's very much like we have this corset, right? And you can try to take as deep a breath as you want into that corset. But if you don't have the muscle flexibility, it's not just about strength, it's also about flexibility, because these muscles of postural alignment, the muscles of respiration, have a tendency towards shortness and tightness. So we need to regain stretch. And stretch without pain and stretch without strain. So it's a fine line there.
Yeah, and I'd also say that there's also the deconditioning aspect. A lot of people have been very sick for a long time, coughing, crunching down like that, being uncomfortable, being in bed. And so coming out of that, there is still this balance to be had between the deconditioning and the reconditioning without causing a problem. So we have a number of our people working with support, like on the floor, stretching on the floor, doing, the snow angels, but on the floor or over the ball, opening up the chest, working on that thoracic expansion, breathing in different ways. And so there is the still go slowly, as we are introducing movement, but definitely that is a thing, trying to create that space.
Mm-hmm. How can, sorry, I just lost that question. If those with long COVID breathing difficulty have damage to the interior of the lungs as seen on x-rays, is working with the muscles of inspiration a way around the damage while tissue hopefully recovers?
Do you want to go first?
Yeah. So damage is damage. I don't know that we know at this time that will ultimately heal. What I do know is that I have lots of elite singers who don't have perfect lungs. They might have asthma. They might have a little bit of COPD. They might have other, things before COVID ever happened, and they have perfectly normal careers. So the short answer is I don't know that we know the answer to that question. We don't know that the damage will heal. What I do know, or what I feel like as a therapist, is that I want to give them every tool possible to maximize what they do have, to see if we can make it viable for what they need to do from a performance standpoint.
Yeah, and I would say, in terms of like COPD functioning and what we see in other lung diseases, just as a side note, I completely agree. We don't know if what's showing up in this imaging is transient or if it's more permanent. A lot of people do have imperfect airways. In terms of COPD, we know that some people who have actually very relatively poor looking pulmonary function testing. They actually function very well in life. And then we have people who have excellent pulmonary function testing with COPD, but they're actually functioning very poorly, like going through their daily lives. So there's really a gamut of that. But in general, when the airways are not responsive, one of the ways to help move air in and out, obviously, is going to be musculoskeletal. So yeah, that's where the inspiratory muscle training and the expiratory muscle training and the breathing pattern retraining comes in handy, because we have to then use muscular processes in order to move air properly in and out. It's a much more complicated answer, really, because we could go much farther with that in terms of gas exchange and everything. But in general, I think using that approach could be helpful.
Mm-hmm. Great. Someone else mentions that they were recovering from hernia surgery and got mild COVID. So a lot of ache and pain now, just walking, and a lot of tiredness. What about voice therapy versus physiotherapy, of some kind?
Rachel, you want to I mean, for me, for me, a physical therapist handles the physical, the physical aspects of things. And sometimes we work hand in hand together, we're doing both speech, voice therapy, and then physical therapy, working on different things. We have different, we try to stay in our lanes, as far as what we do, but yeah.
Yeah, I know for myself, the way that it very often works with us is Jessica will have a respiratory patient who she's, working on the breathing patterns and addressing things from her point of view, addressing the body and all of that. But we know that when the respiratory system is compromised, voice tends to go with it. And in many cases, a little quick retraining, very habilitative skills, especially if you're not a singer, can go a long way with that, just re-coordinating that. So that's how I work. And if somebody's obviously hoarse for longer than that, then I refer out to speech pathology. But there is a great role for physiotherapists in rehab for people who are singers. I think they're actually a very undertapped resource for us, because of course the voice is the body, and speech pathologists tend to be within limits, but we know that the big pain in the big toe can actually really affect the way you feel that high C.
And I think, as you're talking about this, you live in Canada, I live in the US. And I think one of the things we're seeing emerge after COVID from a specialty standpoint is I've seen some amazing work done with respiratory therapists from a breathing and voice, music therapists that have gone, oh my gosh, I want to take a deeper dive into this. And I guess what I would tell singing teachers who might be a little hesitant of, oh my gosh, what do I do? What specialist am I supposed to call? Is to say, okay, look around in your area to see if you can find somebody. If not, I'm certainly happy to help facilitate finding you somebody, or Rachel, I'm sure people. And so, our goal at the end of the day is to help people get better. And that's what's most important. And I'll be interested to see how this all ferrets out at the end, because it's kind of, lots of people have hands in the pie right now.
Mm-hmm. Yeah, there are roles for a lot of people.
Many of us may have seen some of the news coverage about the English National Opera, for instance, a program that they've developed and working. I know Rachel knows some of the folks that have been worked on that program. And so, they've been developing ways to not only work with, singers, but also non-singers by profession in helping treat some post-COVID patients. And I know, Rachel, you're also working on some of that with your group as well. Do you want to
we have
a little bit about that?
Yeah, we have a as I said, we have our program Breathe, Sing, Move, which is essentially an extension of traditional pulmonary rehab, where we use exercise and we use singing, the athleticism of singing, to enforce extending the breath, controlling that breathing pattern. There's some voice skills in that too, getting inflection in the voice. So that's the purpose of that program. When it comes to COVID, though, we have changed the title from Breathe, Sing, Move to Breathe, Speak, Pace. I don't think that in a group setting of people who are non-singers, I don't know that it would actually be appropriate to sing with them. I think that the potential for more damage is greater than the potential for good. And we also see larger programs being offered a lot. There are a lot of people that are picking up on this idea, and I want to express that I am very pleased that we are seeing a role for ourselves in the management of lung disease and chronic disease. But we have to be very careful about how we're going about it and not let our enthusiasm get ahead of us. This is very individual. I have capped my classes at six, but I've seen up to 20, and I worry about what that will do in terms of actually setting people back in their goals. So we have to be very careful. And again, I can't reinforce enough that I do not operate in a bubble. I have a team who is working on this with me. In our program, they have an educational component, they have the physiotherapy component, and then they have the vocal skills component. So it's very targeted, and we are running several of these programs because there's a demand for it, but it is not without a deep dive into the literature first, and really understanding what our understanding of this is, and doing it with the appropriate people hand in hand.
Yeah. What other topics have we not covered? I think somebody asked about just maybe some ideas about some simple exercises we might be able to do with those who are just beginning to get back into lessons. I know you talked about kind of the big picture, Wendy, especially when you were talking, but just give us a few exercises of things that you would use with someone who's recovered fairly well, let's say it that way, not kind of a long COVID person, maybe.
Yeah. So did you want to talk, Rachel? Go ahead.
You can go ahead.
I was just going to say, when I see them back, it's kind of a reassessment of where their voice is. So I start with exercise. I always tell folks, think middle of the road. So mid-range, mid-intensity, just very gentle stuff. The closer, obviously, those intervals are together, the easy. So we might do 1, 2, 3, 2, 1. Then I want to see if they can do 1, 3, 5, 3, 1. Then I want to see if they can do 1, 5. Then we do 1, 8. And then I give them a break. And so then I just sort of see, just super simple exercises. And that's what I do. I don't go, okay, let me see if you can do some staccati initially. Typically, that's not where I'm going to start. Close together exercise, mid-range, mid-intensity. And depending on where we go, then we can expand from there.
Yeah, and in terms of the people that are coming to see me who may or may not actually be, I do have, several singers like Wendy has, but I also have a number of regular people who need some help because they can't speak very well. So I spend a lot of time working on just connecting the breath with the voice in a non-singing way. So lots of humming with chewing, lots of just stick the tongue out and let's say the days of the week. Lots of just finding inflection in a normal range, sighing, and sometimes all that we do is just breathing, right? And you may voice, go from a voiceless fricative into a voiced fricative, back and forth like that. But it's very gentle. And with my singers, it's not, where is the max range? Where is, it's none of that right now. Very basic, and slower is better.
And I'm going to say some of them progress really quickly in my world. Like some of them actually are like, I don't feel great to start with, but I mean, then they progress normally. And then that makes me really happy because that's awesome. But we're talking kind of some of the outliers here. I think, Alan, what's really important to say is I'm not also talking about people who've had like intubation injuries. I'm not talking about that. That's not the long COVID that I'm talking about. We didn't even venture into that, but I'm not talking any laryngeal damage from COVID complications. This is just like, I got COVID, I got really sick, or I got moderately sick and I'm not recovering. That's a whole other conversation. Just to be clear for anybody who's watching.
Yeah, that's a good point. There's so many medical complications that can, happen from intubation and some of the other things that we've seen, and it's really important to know we're not even talking about that sphere of people who've had some of those complications, and so it's really important to make sure that I think again we've kind of laid out here today kind of the ideas of getting a team around you, knowing who you can refer to, finding those resources in your area that you can, whether it's a COVID clinic or those who are in your region who are doing some research, and have either developed protocols and they're working actively with post-COVID patients that can help you and that you can refer them to, and making sure that you understand what the limitations you have as a professional are, so that you just follow some of those great things that Wendy laid out in the red and yellow and green light as well slide, so that we just are really careful about how we're helping our students and clients as they return to singing. We all have all of those. I like to think about, okay, well, if this was the first lesson with a student, I've taught a student for years, go back to this beginning, just think about those very basic first things, and just start there and see how fast things move. Because I think, just like Rachel said, I think we're like, go, get back 100% next week. And we have to accept that timeline is really a lot longer. Well, thank you both so much for being with us today. This has been excellent material for all of us to take to heart and to apply in our teaching and our work with our students and our clients. You guys are such valuable members of our NATS community, and we appreciate the great work and the research that you do and how you apply it to our daily teaching and give us the tools that we need to be successful. So thank you so much for being with us again. And I will let you know and remind you again about some of the resources I mentioned at the beginning of this webinar. We will also put the recording of this, of course, on our YouTube page. We'll also have links to the PowerPoint presentation so that you can have all the links for those. And make sure you look at the description for this session, as we'll also drop some of the information there for your use and for you to refer it to others to use and to your students. I also, while we're here, want to remind you it's a busy next few days of webinars that are not necessarily in this series. Sunday evening is our regular NATS chat series with Kari Reagan. So you can look at the NATS chat page on the NATS website, find out about that. And Peggy Baruti will be one of the guests on that. They're going to be talking about vocal fatigue. So maybe some bleed over from some of the things that we have talked about today. Then next Tuesday, Opera America is hosting a webinar about the audition and demystifying the audition process. And they're going to have some of the major leaders in auditioning for summer programs and young artist programs, and NATS and NOA are both cooperating with them on that webinar. So I encourage you to look for those in the coming days. And we really appreciate your continued support and the continued work that you're doing where you are. We encourage you to stay safe, fight the fatigue, stay masked, and we look forward to the days when we can see you face to face. Thank you so much.
Rather than later. Bye.
Thank you.
Thanks for having us.